properly? Well, basically what it boils down to is when an orthopedic surgeon prescribes a prescription for any type of orthotic, when the patient comes to you with that prescription, it's like when a patient goes to a pharmacy. Pharmacist has to be able to read that prescription and say, well, I got to give him this drug, this drug, whatever. That's the same with an orthotic prescription. You have to be able to read that prescription. You have to be able to understand it. You have to understand an orthotic is to correct some sort of deformity in the body. Now, again, a lot of times, you know, it depends. Is it a fracture? Is it a ligament problem? Is it muscle problem? Is it tendon problem? So again, you get all that in your basic training in your orthotic schooling and stuff. But again, the bottom line is you have to be able to read that prescription, and you have to be able to service this patient,
right,
because you have to send this patient back to the orthopedic surgeon. He's going to check, and if you don't do the right thing, believe me, you're not going to be a happy camper.
Right, right.
But again, the bottom line is stress is knowing how to read the prescription. Because, well, do you want me to twist it? How many degrees you want me to go this way? Which way do you want to angulate it this way? All that sort of stuff. But again, all that comes in your basic training, your 4-year program.
All right. So why don't we define what an orthotist is? We covered what it takes to become an orthotist, but actually define it. And you know, you mentioned something about biomechanics. In medicine, we always say structure is function. So let's focus on what an orthotist and apply structure is function.
Well, an orthotist is a person that actually makes and fits braces, splints, orthotics, etc., stuff like that. Usually you have to find when the patient comes to you what exactly is wrong with the patient. Is there a limb missing? Is there a limb broken? Is there a ligament torn? Is there a muscle torn? Is there a tendon torn? So again, it's a combination of all these. And basically what my objective is then is to design and make something to fit to correct this problem. That's exactly basically what an orthotist can do for you.
So it's important that our audience knows that if a physician prescribes an orthotic device, whether it's a knee brace, a back support, a wrist splint, they need to go to a highly qualified, certified, board-certified orthotist in their community. Fast facts. This is a section where the Ask Dr. Tommy O show likes to go over statistics where we can demonstrate how significant pathology is and how it defines our community. Source: the Prosthetics and Orthotics Research 1992 conference states there are approximately 2,800 American board-certified practitioners in America. It also says the average orthotic program graduates approximately 180 students every year. The majority of students entering the orthotic program hold at minimum a bachelor's degree, followed by a small percentage holding a master's degree. Okay. Orthotics and prosthetists are trained to recognize and analyze dynamic pathomechanical conditions and recommend, design, and fabricate a device on the basis of function and tissue pressure tolerances. According to the American Board of Certification in Orthotics and Prosthetics, in 1972, Educational Accreditation Commission was developed to establish criteria to assess and compare the criteria. The standards of excellence for the orthotics and prosthetics residency program were later developed and revised to meet the professional needs and the training programs. In 1991, the Educational Accreditation Commissioner was renamed to the National Commission on Orthotics and Prosthetic Education. In 1995, the National Commission on Orthotics and Prosthetics Education educational guidelines became gold standard for all orthotic programs. And now we're going to go to the clinical aspect so we can apply the structure and function, and so you can actually see what an orthotist does.
I would love to do that.
And now for the clinical portion of our show. As healthcare providers, well, when we have pathology or a patient that comes in with pathology, we like to discuss the cases between two providers. In this case, Eddie and I, we're going to discuss pathology of the knee. So Eddie, would you explain what we have here? This is called an X-ray. We have an X-ray of the knee. Would you explain what we have?
Okay, generally what we have here, we have obviously X-ray of the knee. On this view right here, we generally call, it's called the AP, which is anterior and posterior. On this side over here, we have what we call the lateral aspect. Clearly on this, this happens to be a patient I'm treating right now, and this happens to be an X-ray of a young 80-year-old female. Actually, this patient was sent to me by Dr. Das, who offered this lady surgery, but obviously at 80 years of age, she's somewhat too scared, and I don't think she wants to take the risks that come with surgery. So in general, what has happened here, if you look at this, okay, this is what we call the femur bone, which is your thigh bone. And then we move down here to the leg bone, which is called the tibia bone. And on the side here is called the fibula bone. Now, if you look in the center here, okay, this is where, on this side, this is the weight-bearing surface. And actually, what's after happening here to this lady, again, because of the wear and tear, like I said, she's a nice 80-year-old young lady, she's completely worn out all the cartilage right here. So when you wear out all this cartilage and stuff, now this causes severe swelling. When you actually put your hand on the knee, it becomes very warm. So basically what I'm going to do here, what my objective here is to put this lady in what we call a medial unloader knee brace. What that does, what this brace is designed to do actually, is when we apply the brace, and I'm going to show you later how we're going to do that. Again, like I said, my objective now would be, if you can see how the space is all open here. There's no complaints, she has no complaints on this side. So again, my plan here is to actually open up this joint line here. So by opening up the joint line, then, you know, obviously we will relieve the pain. Now, again, a lot of people, unfortunately, are on a lot of non-steroidals because of this type of erosion and stuff. And lately, as you know yourself, a lot of these non-steroidals have been taken off the market. So there's really not very much left, either surgery and, again, like I said, the knee brace. So again, the knee brace is designed to, number one, you can postpone the surgery if you're afraid to have it and stuff. And like I said, hopefully it will give some relief. Right. I don't know if I mentioned previously, but I think I checked the statistics in the United States right now. There's probably about 21 million people in this country suffering from this problem right now. So that's
pretty significant.
Yes, very significant.
Okay, if we could just zoom in, because I like to point out, because we're addressing the space in between the thigh bone and the leg bone, all right, the femur and the tibia. We have a nice open space here on the lateral aspect. On the medial aspect, there's almost no space here, and this is where all the problems is. As Eddie addressed, this is the weight-bearing surface of the thigh and the knee itself. Now, with a patient, let's say a patient comes in to see me with the chief complaint of knee pain and grinding with leg movement. The first thing we would do is, do a thorough history and physical, and then send for an x-ray. So a patient comes to me, and then we discuss this case, and we see something like this on the x-ray image, or the radiograph. That's what it's also known as. The first thing I'm going to do is I'm going to determine whether or not I should treat this conservatively or aggressive. And we all have to look, as physicians and providers, we have to determine risk versus benefits and how aggressive we have to be. But let's say I decide to take a conservative approach and then prescribe a knee brace. Well, as a physician, I might just prescribe just a general knee brace. Now, from your perspective, would a prescription for a general knee brace